Again, I appreciate you all being here this afternoon, and I think you're in for a real treat here with our last panel discussing the state of mental health services here in the state of Missouri. Even though Missouri has taken a lot of cuts over the last 4 years, one of the things that we've been fortunate to have here in our state are very committed, creative people working both within our mental health system as well as out in the community as part of the larger mental health community here in the state of Missouri. And the individuals sitting on this stage should be very familiar to those of you who've worked in the mental health system here in the state of Missouri, because they've all been involved in the system for a long period of time, all coming at the mental health system from a little different perspective. So what I want to do is briefly introduce the 4 panelists for this afternoon, and then their full biographies are in your packet, so if you want to get a little more information about them, please feel free to look at those. And then at the very end of the panel presentation, we will go ahead and take questions from the audience. So the first individual who's going to be speaking today is Dorn Schuffman. And Dorn was the director of the Department of Mental Health here in the state of Missouri, and is back now in a senior consultant fashion and coordinator working on their primary behavioral health care home transition that the department's going through right now. And it's going to be a very exciting process over the next 5 years in this state as this rolls out as a statewide program here. Tim Swifford, who joined the Community Advisory Committee in 2007, is the Chief Executive Officer of the Missouri Coalition of Community Mental Health Centers. He's gained a considerable amount of experience in management and mental health care at Burrell Behavioral Health, where he served from '91 until 2005. Senator Sims, she will always be to me, Betty Sims, who served as a state senator from 1995 to 2002 here in the state of Missouri. At various times as a senator, she was the assistant floor leader, chair of the Aging Families and Mental Health Committee, and vice chair of the Committee on Civil and Criminal Jurisprudence. And any time there was a bill pending towards the Missouri General Assembly that had anything to do with health or mental health, Senator Sims was always a huge champion for those causes here in this state. And then last but not least, an individual who I had the fortunate opportunity to intern with when I was a graduate student here in the state of Missouri, Tim Harlan, who is a graduate of Westminster College and the University of Missouri-Columbia Law School. And for the last several years now, since his retirement from the General Assembly, he served as the president of the National Alliance on Mental Illness Missouri and of NAMI Columbia. Welcome all of our panelists today, please.
Thank you. Thank you, Nancy. As Nancy said, I'm Dorn Schuffman. Yes, I was former director of the Department of Mental Health, but I'm not now. But I am working with the Department of Mental Health, particularly on the healthcare home and integration initiatives. So that's what I'm going to focus on, and I'm going to let my colleague, Tim Swinford, who is actively involved in everything that's going on in the state, talk to you a little bit more about some broader issues for the state of Missouri and at the national level. So I'm going to give you a little context for the healthcare home initiative that's being initiated in Missouri, and then give you some meat for the bones. Your keynote speaker, your mental health keynote speaker, prepared me very well for this. I'll just emphasize a few things that he said as sort of a context for this. Going back a few years, we started probably in the late 80s, I guess it was, focusing as states and as at the national level on people with serious mental illness and children with serious emotional disorders. Prior to that, we were a little bit more scattered in our focus, but in the late 80s, probably early 90s, we started to focus on that population. And that led in Missouri and in many parts of the country to developing programs particularly focused on that, using Medicaid as a funding source, and in this case the rehabilitation option under Medicaid. And in Missouri we developed what we call the Community Psychiatric Rehab Program, which brought all the services around people, focusing on things like housing and employment in addition to their psychiatric disorders. And a little bit later than that, and your keynote speaker mentioned this too, somebody got the idea that you could recover from mental illness. And what a big difference that has made and continues to make. You know, we started to realize that people could recover from mental illness, and that in some ways their self-image had been damaged, maybe their skills had been damaged, maybe they had lost some sense of who they were. And so part of the task became to help people reclaim a sense of self, which was maybe expressed in having a sense of independence, reclaiming a sense of independence, but also a sense of belonging, that they weren't isolated, and also a sense of responsibility, that they were in control. In fact, recovery is something I do, not something you do to me, which is a big difference than being treated. It's something I do. Also, people needed some help with reclaiming mastery, their skills, and maybe with meaning, which often comes from playing different roles, being a brother or a father or a student or a husband. And some of those roles had been lost and needed to be restored. And most important, reclaiming a sense of hope, which sometimes comes from having people believe in you, very importantly. That's very important. I think that's what we do in supporting people. But very important to that is having role models, peers. And that's why peer services and peer leaders are so important. Somebody who's been through it that you can look to and see they're doing well. So the recovery model came along, and that was moving us in a direction that might have taken us to where we are today, but maybe not as quickly as some other things. The main thing, and your keynote speaker mentioned this, and we were fortunate to have Joe Parks lead the study that the National Association of State Mental Health Program Directors did on the morbidity and mortality of people with serious mental illness. And that's the study which I'm sure you're all familiar with, and certainly he mentioned about people with serious mental illness dying earlier than they should, and much earlier than the general population. Because Joe was involved in that, and he was here, that spurred a lot of activity in Missouri and gave us a real head start on a lot of the other states in the nation. There's some other studies have come along that kind of confirmed and maybe even really dramatized the findings of that study. I mean, it's very clear in smoking. We know smoking, hypertension, diabetes, the smoking, 68% roughly, some places more, people with serious mental illness smoke compared to roughly 35% of the general population, more than or about twice as many. I remember when recovery came around, recovery model came around, we were saying, yeah, mental illness is like diabetes. You can live with it. You can recover from it. And of course now we recognize that many of the people also had diabetes, and we weren't paying attention to that. He also mentioned that the new generation psychotic medications are very effective, but do have some side effects, and many places haven't been paying attention to that. In fact, a recent study showed of Medicaid in at least 3 states showed that few Medicaid patients starting second-generation antipsychotics received the recommended serum glucose treatment or lipid testing that's required if you're going to take those medications. So all of those things began in Missouri earlier than most places to broaden our view of what we ought to be doing. And a key part of that, I credit the Coalition Community Mental Health Centers, reaching out to their colleagues in the Primary Care Association, the FQHCs, and starting a dialogue with them, getting together with them to say, you know, we need your services. Our people don't access primary care. What can we do? And working together with them to try to improve access to care for people in Missouri. That also led the Department of Mental Health to fund an initiative for FQHCs, federally qualified health centers, and community mental health centers to collaborate in integrating their care. And several centers in the state collaborated to introduce primary care into the CMHC setting and to add behavioral health specialists to the primary care teams at the FQHCs. Other things that happened along the way that really prepared us to be where we are, the introduction of Cyber Access, which is the Medicaid health information technology system that allows people to go on providers to go on and look at all kinds of information that helps them understand what's going on with the individuals that they're serving in terms of their past services and other services they're getting. That enabled the Department of Mental Health to do some special sorts of reviews and studies, and over the last several years have been providing particular reports to the community mental health centers about the clients that they're serving. Things like being able to track people's use of their medications, or at least whether they're filling their prescriptions. As the keynote speaker mentioned, and as you know, if you don't take the medications, they don't do you any good. We started by looking at the psychiatric medications and saying, are people filling their medications? We give them the prescriptions, but are they filling them? And letting providers know that your person hasn't filled their prescription for the last 2 months. We also started looking at the use of the prescribing methods of the psychiatric medications, providing reports on whether people were getting medications from multiple providers and how many medications were they getting. Did your psychiatrists know they're getting 5 antipsychotics? Where are they coming from? Also looking at the indicators. Are they getting a level that's indicated? Now, sometimes there's a reason not to go by the indications and to work outside those, but to at least let prescribers know that this person is getting a dose that maybe is higher or lower than is recommended. When we started to look at not just psychiatric issues, but general health care issues, we also looked at the medications for diabetes and for cardiovascular disease. Are they filling those prescriptions if they've been prescribed those? And we are able to provide reports to the CMHCs regarding whether or not people who they're serving, if they have a diagnosis of asthma or COPD or coronary artery disease, has anybody prescribed them the medications that go with this diagnoses? And for people with diabetes, is their A1C level and their lipid levels and their blood pressure levels, are those being controlled? We can track that and we can report that back. Similarly with hypertension, is their hypertension, if they're diagnosed, being controlled? Because we started providing all that information to people, it was pretty clear somebody needed to understand what it meant. And so the Department of Mental Health started providing nurse liaisons. Now, in most cases, it was one person or maybe a part of a person to a mental health center to start looking at those reports and saying, what is this telling us? How can we use this information? Slightly later, we started requiring all of the centers for anybody who's on a second-generation antipsychotic to do metabolic screening, to do the testing that's required if you're going to actually know that you're not causing side effects you don't want to cause. And many of the centers started getting into doing healthy lifestyles emphasis, having exercise programs and even weightlifting and all of that at their organizations. All of that was preparing us for where we are now, which is moving toward the community mental health center healthcare home model. And really, this is not just a new program, though in some sense it is, because we're introducing some new elements. And it's not just a new Medicaid benefit, which it is. It's much more than that. You can see that we've actually been transforming what a mental health center does. Not just focusing on their psychiatric disorder and providing good rehabilitation services, but seeing that the responsibility is to look at the whole person and to assist in meeting their needs across a wide array of issues, and particularly their health care needs, since this population is underserved in accessing primary care and overrepresented in having certain chronic diseases. People are eligible for the healthcare home, CMHC healthcare home, if they have a serious mental illness or they have a serious emotional disturbance if they're a child, or if they have a mental health and substance abuse disorder and it's not serious, in the serious category, or if they have a mental health or substance abuse disorder and they have cardiovascular disease or chronic obstructive pulmonary disease or asthma, diabetes, or if they're overweight, or if they smoke, or if they have developmental disabilities. Even by listing that, you can see that the focus is no longer just on psychiatric disorders. Initially, about 16,500 people will be enrolled. There is another component that Tim's going to talk about a little bit that's sort of an outreach component. But initially, about 16,500 people that are currently clients of the, or consumers of the mental health centers will be enrolled. We've targeted the 16,500 people because they are very high users of services in the system. So we've taken the high users and said, let's start with those. We figure those are the people who have the most need as a marker for meeting their needs. The responsibilities of a health home is to do a comprehensive health screen, in addition to doing all the psychiatric rehab that they do. Comprehensive health screen plan, promoting healthy lifestyles, accessing needed primary care, including working with the PCPs, the primary care physician for the individual, or getting a primary care physician for that individual. Assisting them in managing their chronic conditions, their diabetes, their asthma. And for a long time, we've been working with psychiatric hospitals and admissions and discharges. Now the mental health centers will get emails daily if anyone who is in their healthcare home has prior authorization for admission to any hospital for any reason, so that they can follow up with the hospital and do discharge planning with them. They're required to develop a memorandum of understanding with the hospitals in their area. In order to do this, we're enhancing the programs of the mental health centers to include a primary care consultant as part of their team, a physician who brings that primary care expertise. And we're converting what were the nurse liaisons, who were basically tied up with looking at all the reports and trying to figure out what to do with them. We're converting them to nurse care managers and greatly expanding the number so that they are now part of the rehabilitation team. And we'll be providing over the next several years significant increased training to community support specialists, who are the people who are daily working and supporting these people in a rehab option, who are the people who really change people's lives. Promoting so that they can better promote healthy lifestyles and preventive care, better know how to help people manage their diabetes and other chronic conditions, and better know how to access and work with the primary care system. It's pretty exciting. It's just beginning, and it really has some implications for the future. As I said, there is an outreach component to it that reaches out to people who are not in the system, and there obviously are some implications for Medicaid expansion that will impact this, but I'm going to let my colleague Tim talk about that. So, Tim Swinford.
Thank you, Doran. And I don't know if I'll specifically cover what he thinks. The interesting dynamic when talking about the Missouri public mental health system is that, as our NAMI presenter talked about earlier today, we've had substantial budget cuts. And most of those budget cuts have applied to downsizing of state hospitals and reduction of access to care for the non-Medicaid population. So access to care in a community level is what the community most often sees. What they don't see is that Missouri's service delivery model is leading the country in a number of areas, particularly around integrated care for persons with mental illness. In fact, just in the last 2 weeks, I've been asked by 7 states to talk to them about our history and all the things that we're doing, and it's quite different than it was 6 years ago. And I'm not going to talk about the study. I'm going to talk about what was going on around Medicaid in Missouri 7 years ago. We had a Medicaid Reform Commission looking at how we should design the Medicaid program. And we took to, the leader of that was Senator Shields, who later became the Senate pro tem. And we took our great outcomes on psychiatric rehabilitation, how people with mental illness we kept out of the hospital, psychiatric hospital, how we helped them get independent housing, and how we helped them on employment. And he looked at me and said, that's really good. Do you help them with their overall health? And do you save money for their overall health? And do you improve their health outcomes? And I said, I'll get back to you on that. Well, one of the outcomes of the Medicaid Reform Commission report was the collaboration between community mental health centers and FQHCs as part of that very question. But we did look at that, and we did a study on what happens when a community mental health center, when a person who wasn't in a community mental health center got care from a community mental health center, and what was their health cost and their health outcomes. Their health cost, we do not just bend the cost curve, we flatten the cost curve. We actually lowered cost on people that came into our system, which has really been part of the framework of building an enhanced package to even do that more. So the next sort of initiative that really looked at this was that the Department of Social Services hired the Lewin Group to do an analysis of the Medicaid program. Seems like we're always doing analysis of the Medicaid program, but one of the pieces of, that was found in that was that there was over 23,000 Medicaid recipients who were not dual eligibles who had $25,000 in health cost or more. But 85% of those had at least one claim for a mental health diagnosis. 30% of those had no office visit for mental health. This is right out of the Lewin report. It's on the Medicaid Oversight Committee website. So one of the exciting initiatives that has occurred is that we have the data to show that psychiatric rehabilitation saves money and improves quality of care for people that we're not serving. We have the Lewin report that says there's a lot of people you're not serving that cost a lot of money and aren't getting good care. Let's try to do services a little different. Instead of waiting for people to come to us, instead of waiting for them to see if a hospital refers them and they actually show up, instead of a family member referring them, Medicaid provides the information of the high-cost recipients to the community mental health center to go and outreach to them. That is the new initiative, and the budget, last year's state budget, was predicated that we would save over $1 million by doing that. We have now enrolled over 1,500 consumers in that initiative, and we have once again flattened the cost curve on those individuals and identified really critical health care needs that continue to be policy initiatives around that the health care home alone won't solve. Over 80% of those individuals have dental needs. 50% of them had an emergency visit in the month prior to us picking them up. So this initiative is already showing cost savings and is already showing quality outcomes. And they're all getting metabolic screenings to see if they will not, so we can prevent their diabetes or metabolic disorder. That's just one of the exciting initiatives, along with the Health Home. That's called the DM 3700 project. And between those two initiatives, the Health Home and the DM 3700 project, that is what all the states want to hear about. And it's quite different than it was 6 or 7 years ago, where we had all these other proposals of how things could be better. We're now what other states are looking at as the way to enhance care and save funding on the Medicaid program for persons with mental illness. Problem, though, still is it doesn't reach the people who don't have any sort of coverage or Medicaid. Another piece that I want to talk about, because addictions was listed on the is listed in your packet of something I was going to talk about. We also have a very unique corrections partnership in Missouri. And that program, we are reaching out to probation and parole office referrals and level 4 offenders leaving prison at the end of their sentence. And that was a state budget item. But the significance of this is it isn't going to the addictions population at this point in time. And one of the largest growing pieces in state budgets has been corrections. Over the past 25 years, there's been over 4 million more people in the country going to the corrections population. In the first 2 weeks after release from prison, former inmates are 129 times more likely to die of a drug overdose than those members of the general population. Over 50% of the drug prisoners nationwide meet criteria for drug dependence. And going down a different path, prescription drugs. Over 12 million people use prescription opioid drugs illicitly. That'd be pain relievers, tranquilizers, stimulants, but what you'll hear most about is OxyContin. So where Missouri has also become a leader is in medication-assisted treatment, in which a person can get a prescription that relieves the need to the symptoms of the addiction. But these initiatives that we've implemented, we have very good healthcare diversion programs. We have some mental health corrections diversion programs. We have drug courts, but what we don't yet really have very well established is post-discharge from prison populations. And fortunately, I think there is a commission looking at that in Missouri, because that population, what you hear from county jails, what you hear from state corrections officials, is that what they're calling mental health. The people that are being called mental health consumers, a lot of that is addictions, and a lot of it is anxiety disorders and depression. So that's another opportunity for reform. Now, the last thing I want to say about the system reform around healthcare home is that if the Affordable Care Act does proceed with coverage for Medicaid recipients, the scary part for states is that the feds will pick up that budget bill in the early phases, but at the end, the state will pick up a portion of that. If our projects are successful in the healthcare home, where we've flattened the cost curve, the state won't have the big pickup at the end. So that's my overview, and I'll turn it over, I think it's to Betty Sims.
Okay, are there any psychiatrists or psychologists in the room? Great. I'm not talking to you, okay? Pull it down? Can you hear me? Okay. If we were really doing mental health first aid, I'd make all the people on that side get up and move over here, because it's very hard to do like this. But anyway, let's get started. What is mental health first aid? Mental health first aid is a groundbreaking public education program which introduces participants to the risk factors and the warning signs of mental health problems. It reduces stigma, and it builds understanding of mental health diseases and overviews of common treatments. Basically, it's a 12-hour course facilitated by trained, certified instructors, emphasis, which teaches, 1, the signs and symptoms of common mental health diseases, 2, evidence-based treatments, and 3, develops an action plan for crisis situations for first responders to use until appropriate help can be accessed. First aiders learn how to help an individual in a crisis connected with appropriate care, be that care professional, peer, social, or self-help care. So how did it start? Well, it started in Australia with a gal named Betty Kitchener. Betty Kitchener is a nurse, a special educator, a mom who had personally experienced depression. Her husband is Dr. Tony Jorm, who is a well-known research psychologist from the University of Australia at Melbourne. And Betty and Tony were out walking one night, and Betty said, you know, isn't it strange? Why don't we have a program like first aid? Everybody here know what first aid is, ABC, first aid. Why don't we have something like that for mental health? And they talked about it a little bit further. And Betty is one of these people who has a gorgeous voice, and she just keeps talking. And she decided it was such a great idea, she'd go home, she'd get a few friends together, they'd start talking further, and begin to build something. What they built was this course, Mental Health First Aid. But she had the advantage of having Tony, who then used the Delphi procedure to verify that every single thing in the program is indeed totally evidence-based. The thing has been peer-reviewed to the ultimate, has so much documentation that it's just magnificent, which gives it the thrust to then travel the world over, and I'll get into that a little bit more. They convinced Australia, through the Australian healthcare, that they should get involved. And eventually it spread to every province in Australia. from there to Shanghai, then to Canada, then the United Kingdom, and now it's in 17 countries, just having been introduced in Israel. The interesting thing about it, and to me, it was shocking. I had the opportunity to meet the head of the National Public Health System in Scotland. And Scotland has a population of about 5.6 million people. Missouri, 5.6 million people. The director told me that they plan to train 10% of their population within the next 2 years. That's, 560 people in 2 years. Let's put it this way, in 5 years, we've maybe trained 100 instructors. They're moving, they're just moving beautifully. But then the question comes, well, okay, they're out there, they're moving all over. How did it come to the United States? Well, as somebody said, you never met Betty Sims. Basically what happened, and this is true, I had the opportunity to work for the Department of Health after I was in the Senate, and was asked, would I be interested in representing the Department of Health on the Transformation Committee, looking at changes in mental health. Everybody here know what the Transformation Program was. The state of Missouri received a grant, as 9 other states did, and we used that money to really do some wonderful changes. But with the transformation study and being on the steering committee, they had a lot of pilot programs and a lot of different groups, and eager to be a volunteer that I am, I said, okay, I'll be on all of them. So I went all over the state, traveled with these different groups, and I kept hearing the same thing over and over again. Stigma, no access, nobody understands mental illness. No, we're not, stigma, stigma, stigma. Exactly what you just heard Ron talking about this morning. At the same time, I was sitting on a committee called the Reforming States Group, which is a group of legislators and executive branch people from all over the country representing all the states, funded by the Milbank Foundation out of New York. And we were meeting in New Orleans. I had just been to one of these focus group meetings, and at the meeting in New Orleans was Betty Kitchener, talking about mental health first aid, talking about stigma, talking about how the program could overcome it, what they were doing. And I'm thinking, ding, 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 this is what we're talking about. This is what we need. So at the same meeting was my colleague, John Calmers. Luckily, John Calmers is the Director of Health and Mental Hygiene for the state of Maryland. I said, John, are you going to do it in Maryland? He said, well, we're thinking about it. And I said, John, if you do it in Maryland and we do it in Missouri, could we do it together? Answer, sure, if I could get the approval from the state of Missouri. Well, I came back and went to see Keith Schaefer sitting at his desk, feet up. And I said, Keith, what do you think? He says, you like it, Sims? I said, I think it's just fantastic. He said, then go do it. Beginning of mental health first aid in the state of Missouri and in the state of Maryland. Luckily, John is still the Director of Health and Mental Hygiene in Maryland. At the same time, Betty Kitchener had done some work with the National Behavioral Health Council. We didn't know they were doing that, so the two states are kind of thinking, how are we going to put it together? Meanwhile, the National Behavioral Health Council is coming in, and they're thinking about how they want to do it. Well, we went to SAMHSA, and we're thinking that it would be, we can't put together a program to affect the United States. If all these other countries are doing it, we don't want to do something in the United States and have it done in 50 different states all differently. We've got to do it united, and we've got to be faithful to the program. And that is absolutely the #1 rule, fidelity to the program. So we got the support of SAMHSA, who then, of course, knew that the National Council was involved, and they said, fine, you 3 do it together. Anybody ever worked on a committee with 3 people? Fun and games, it is not. It was unbelievable. And the first thing, and we're all friends, we're all interested, we all have the same goal, kind of in different manners. First thing we had to do, and I'm really excited about it, was we had to take the material that Betty had written in Australia, and I say Australiese because that's not really a word, and write it in United Statesese, which is not another word, because they're different and they talk differently and they write differently. And so the biggest thing we had to come up with was the training manuals and the manual to be able to make this course and make it viable. Luckily, we used the University of Maryland Press. It took almost 2.5 years, and da-da-da-da, we have mental health first aid, the manual. And this manual now, 15,000 people have taken the course in the United States already. Everybody has the same manual. Now, the interesting thing about the manual is the manual doesn't match the course. And they go, ah! But the manual is the resource that you have during the course and after the course, and is a wonderful resource. I mean, as a layperson myself, I have used this several times to go back and say, yeah, I think it's right. It talks about resources, talks about the diseases, talks about the plan and how you relate to them. It's fabulous. At the same time, we have the Mental Health First Aid Training Manual. And the training manual is to the word what you will teach. No variation. Fidelity is fidelity. Do not waver. And I mean, it has every slide and every word. But of course, you have to add more words than that, so you have to know something you're talking about. But every instructor uses the manual. Therefore, we all are teaching now in 43 states the same program. And if you think that isn't a game, you're wrong. The three partners established the memorandum with understanding with the support of SAMHSA, and SAMHSA actually gave us about $150,000, which really went to help develop the manual. So we had a nice start. And the first trainers were beginning to get trained. We started with some trainers out of Maryland. They came to Missouri, and the first time we heard them, I don't know, Nancy, if you were there, but it was awful. And we kept saying, that's not what we wanted. That's it. And so we called Betty Kitchener and we said, we're missing the boat here. We're not making a course that people would really want to go to. Why would a layperson want this? So Betty agreed to come over herself and teach the course. And she taught a course in Jefferson City. I have to say, I was a privileged member to be part of that course. And guess what? I'm still teaching the program. In fact, teaching it next week. So that was wonderful. And Betty said, you're absolutely right. We got to lighten this thing up. We got to make it fun. We've got to make it so people enjoy taking it and that they learn something. And I think that is critical. So then comes the question, well, what's in the course? And I think we've heard enough today about recovery. We believe in recovery. And we believe that it's important for people that are taking the course to begin to understand what it's like to be a patient with a mental illness. Looking at the holistic support, looking at the individual and the person, looking at empowerment, but mostly having respect. And that word respect is over and over. So the course is teaching those words, teaching those issues, so that when you finish taking the course, you really feel like you understand what it's like to be mentally ill if you yourself have never really had that opportunity. And I would like to say, I think the way we're going to sell this thing is I now know that 1 in every 4 women has some phase of depression during their livelihood. I think, gentlemen, the women will begin to teach you what mental illness is all about, and eventually we'll take care of it, okay? We will be able to support it. So as we look at the course itself, it's basically divided into 4 sessions. It's 12 hours long, and we don't care how you teach the 12 hours, meaning you can do it in two 6-hour courses, you can do it in 4-hour courses, you can do it 3-hour courses, which is, I kind of like 3 4-hour courses, kind of makes it nice, but you can do it any way you want, and that depends on the buyer of the product. But still divided into 4 basic sessions, and we look at the different diseases. We look at depression and suicide. We look at anxiety disorders. We look at substance abuse disorders. We look at psychotic disorders, and we look at eating disorders. And we're not making psychiatrists or psychologists out of us. We are lay people who are learning how to recognize in an early stage a potential mental disease. That's all we are. I mean, we are not professionals, nor will we ever claim to be. We have developed along the line the plan, as we call it. And the plan, basically, for every disease, every first aider uses what's called ALGAE. And I need to introduce you to ALGAE. ALGAE is the koala. It's the national symbol for mental health. And ALGAE, Mental Health First Aid in the United States, this ALGAE wears an American eagle, mainly because he came from Australia and he came to me with the eagle on him. And if you think about it, think of the letters in the word eagle. E-A-G-L-E. ALGAE. A-L-G-E-E. They're the same letters. And we thought long and hard about making an eagle for our mascot. And then we thought, no, this was developed in Australia. Let's use the koala. So this is the mascot for ALGAE. Now, what is the plan? ALGAE, A. Assist for the risk of suicide or harm. That's the first thing. A situation's happened, be it a traumatic situation, be it a crisis situation, even to seeing a person. Is there a potential of suicide here, and is there a bit of harm? And we learn how to say, are you considering suicide? It's the one question that every first aider must practice asking. It's not easy. And you'll get the straight answer. If the answer is yes, they will tell you. If it's no, they'll say, are you out of your mind? And they'll go on. It's amazing. That has been verified. The second L, listen non-judgmentally. Anybody knows me and this mouth knows how hard that was for me to listen non-judgmentally. But there's a quote in the manual forward that I like to use. The most basic and powerful way to connect to another person is to listen. Perhaps the most important thing we ever give each other is our attention. A loving silence often has far more power to heal and to connect than the most well-intentioned words. Listen non-judgmentally, and we practice that as part of the program. G, give reassurance and information. So we assess for risks of suicide, we listen non-judgmentally, we give reassurance and information, we encourage appropriate professional help when necessary, and then we encourage self-help or other support strategies. Now, the whole of ALGE might be applied in a certain situation. Other situations, you might only need one of them, or you might be able to hop from one to the other. You might realize it's not a situation of suicide or harm, but you know, if this person would get involved, particularly in depression in older people, sometimes it's no more than saying, wouldn't you like to join the church group on Tuesdays? Or go back to singing, which you used to do when you were younger. I mean, there are a lot of different ways to encourage people to get involved. How's the program coming along? It is coming along, thanks to the fact that it's coming on the East Coast and it's coming along in Missouri. And interesting enough, from the beginning, John envisioned that Maryland, being an urban state, would take pilots in the urban community. Missouri, being the rural state, would be a wonderful partner. We could begin to test the program in the rural communities, and as such, we really have. As I mentioned, there are now 15,000 first aiders nationwide. There are about 1,000 instructors, about 100 in Missouri right now, and we have touched 43 states. We have a website called mentalhealthfirstaid.org, and we also have a website in Missouri called MissouriTransformation.com. If anybody is interested in finding more information or in possibly wanting to be an instructor, you can contact that MissouriTransformation.com, and they will send you on to the proper situation. We started out, and we found it to be very successful by developing partners with different groups. And we partnered first, of course, with the Missouri Health Foundation, who gave us a very significant grant to serve the faith-based community in rural Missouri. We found that the clergy and the faith-based community were a good partnership and one that we could have good relationship with. Didn't happen so well at the beginning. We couldn't get enough people to take the courses. We'd get them excited, but then they didn't want to put together the course. They didn't want to spend the 12 hours, I don't know which, but we suddenly are on a roll now, and that grant will go through 2012. And the good part about the grant is that we actually will pay instructors to teach it, and we pay the manual course, so that it's really exciting. And suddenly NAMI's gotten on board, and they're very excited about it. And so we're beginning to fill up and use up that grant, which is really exciting. We've been working with the Department of Corrections. As we were talking about, all parole officers will be taking mental health first aid, another area in the criminal justice field that we thought was important. We have a pilot with the Moberly School District, and that's exciting to us because, and I'll tell you a little bit more about what's happening in the future, but the Moberly School District is taken on to teach all of their staff people and their faculty in mental health first aid, even though the program is primarily set up to work with adults. We'll get to the youth part in a minute. If anybody is interested in taking the course of being a trainer, the trainer's course is a 5-day course. It is very, I think it's hard. I thought it was hard. It's very intense. And at the end, if you can't get it, if you're not with it and you didn't buy it, they will not allow you to be an instructor. You have to pass, which is interesting because we've had that. We've had some people say, well, we'll get so-and-so to come. So-and-so doesn't really want to come. They come, they kind of go through it. They don't want to be part of it. and they do not make a good instructor. We find the good instructors are people that have had some experience maybe in doing instruction with other programs, like people, get along well. I mean, what you would normally think of as good instructors, make good instructors here. Also, so do professionals in the mental health field. It's always good. We like to teach in teams of 2, and I've always found that if I have a mental health professional with me, it's wonderful, because sometimes the questions that come from the audience, and the classes are about 20 to 30 people that we teach at one time, so that you can get some pretty tricky questions. And the cost is about $1,800 to take the course as a trainer. Although, as I said, right now we have some scholarship money still available through the transformation dollars. So there are some scholarship. If anybody's interested in being a teacher and would be interested, contact the Department of Mental Health. Also, the program is now moving to St. Louis. It's been in Jeff City through the transformation grant. It is now moving to the Missouri Institute of Mental Health, and Dr. Joe Parks is heading up the program. I thought he was going to be here today. I can kind of needle him, but he isn't. And we're working with the University of Missouri at St. Louis to design a research project so that we actually have an evaluation of the United States program. We have the evaluation from Australia, but it's really interesting how many people, particularly funders, want to have an evaluation. Does this work in the United States? You know, it's all well and good to talk, and you're telling this good story. Does it really work? I have to tell you my own experience, and honestly, I've taught the course twice. The second time, though, was to a batch of Girl Scout staff, to the Girl Scout Council of Greater St. Louis. And last summer, as you all know, or you might not know, but anyway, they had a fire at Camp Tuckahoe, and it was the swimming pool area burned down. And of course, kids are running around all over the place. And I got a call from one of the gals who had been in my course, and she said, I just have to tell you, she said, all I could think about was you saying, be calm. Now you be calm. You're a first aider. Be calm. And I thought, I did it. I taught somebody something. So that you just don't know where it's going to happen. And I don't think their kids were in major mental health crises, but I know that the message was a good message, and somebody took it on. The exciting future is we've had such a demand from instructors at schools, particularly high school, both parents, instructors, youth, on doing a manual that will be mental health for adults that work with adolescents. And the reason I know Maryland got into it at the beginning was because of the Virginia Tech situation. We certainly have been involved in the Missouri situation, the whole Arizona thing. But anyway, the youth manual, if I were a lucky woman, I would say I would have it today. It's that close to being ready. The youth manual is being done, and again, nothing is easy. Rather than going back to the University of Maryland, there was a reason they couldn't do it. So the group decided to go to Georgetown University. So Georgetown University is writing the youth manual. And Betty Kitchener had written, I mean, they take hers. They take the Australian manual, they bring back. They brought it back, and as somebody said, it was so academic that nobody could read it. I mean, it was just absurd. So they had to start over again. I mean, they literally had to start writing it like the way a lay person would read a manual, particularly a lay person that was going to teach adolescents. So it's like nothing is easy. Nothing comes, but it is moving, and it's moving fast. And I guess if I ever had a passion in my life, this is a passion that we all end up with respect and love for the mentally ill. And if we learn about it, and all of our friends learn about it, and the moms learn about it, and every businessman learns about it, it will happen. Thank you.
Senator, your comments about judging brought back memories. I thought, have I ever been judged by Senator Sims? Yes, a few times. And we always worked it out. If it seems like I'm rushing, I probably am, because I would like to be able to cover all this. But I'm trying to think of what I know from being a lawyer or a legislator. or the president of NAMI that might be of some help to you. And I think the first is when you're talking about legislators, what do they know, what do they care about? And I just have to start at the bottom and work up. We'll put Senator Sims at the top, but on the other end, when I was handling the parity bill in Missouri, it was the last night. The session ends the next day. The bill is stuck in the Senate. The chair of the committee over there will not let it out, even though the HMOs are begging him to, because I have one of their bills that I can live with. He doesn't want to do it. So the senator comes over to see me, and here's the first question. Tim, are we really just talking about poor people? The second is, do they ever really get well? And the third was, in my town, we have a social worker that comes to the courthouse half a day a week. Why isn't that enough? Why do we need all this other stuff? The other was arranging a meeting with a local NAMI group with a powerful legislator, which meant that I had to drive the night before, stay all night, go to the breakfast I wasn't interested in. So the folks from NAMI come in, and the local president says to the legislator, all of us here have a mental illness, serious mental illness, except Michelle, who is the president of the board. And the legislator just grins and says, well, I have a mental illness too, I'm just dumb. And I just could have crawled into the table, because I thought, what did I bring these people in here for, to be treated like this? But when we went back to their office, I said, well, maybe that was a good thing, because now you understand why you have to advocate. You can't assume that, in this case, the second most powerful person in the state has any interest in this at all, or knows anything about it. He does not, and he won't unless you talk to him, and it has to be pretty serious talking. So those are a couple of, I think, stigma issues. Mental health is the fastest growing part of Social Security disability. That's what I do all day, every day. The reaction from Social Security is not, how can we accommodate these people, or how can we help them? The reaction is, how can we keep them from getting disability? One of their pet peeves is if you have an IQ 1 score under 70 and you have another severe impairment, then and if it's a lifelong condition, you're probably disabled, because there are so few jobs that you can do when you have an IQ of 70. And a psychologist told me 20 years ago, every day there are fewer jobs for people with an IQ of 70 than there were the day before. So now we're 20 years later, that's a lot of jobs. Their response is, particularly in that situation, let's see what we can do to make sure that those people are not able to get disability. At your house, you might not get super lawyers, which I had Post-it notes on. But the cover story is about a lawyer who is an excellent trial lawyer, who I've known for a long time, who had a bout with cancer. She describes that, how difficult that was for her personally, that she is a much better lawyer for having gone through that. But if you would substitute for that major depression and her descriptions of going to the office after she'd lost her hair, things like that, and substitute for that, I couldn't get out of bed all day, I couldn't take a bath for a week, I didn't want to talk to anybody, I cried all day. You're not going to see that on the cover of Super Lawyers. And that is a stigma issue that we still have to deal with. Probably most of you have an idea of what parity is, but we would regularly see insurance policies that said we'll pay $1,000 a year maximum for mental health, or 50% of an office call. Also, even later, after people had somewhat abandoned that, still making some attempt to keep from paying those. Now, when was the last time you saw a policy that said we're going to pay 50% on an office call for cancer or for heart disease? That's the stigma issue, and that's the advocacy issue. Those are much easier to advocate. When we were working on parity, I met with about 6 legislators that I thought I could convince. I turned out to be dead wrong. They all agreed to vote for what we agreed on, and then out of the 7, 6 voted the other way because it's a hard vote. And one of them said, I can't go home and say, because the issue is substance abuse. The Department of Transportation in Missouri tracks their costs. They're easier to track because they're self-insured, but they spend almost as much on a few people on substance abuse as they do for many more for the rest of the mental health budget. But one of the legislators said, I cannot go home and say I helped drunks. Now, that was 7 or 8 years ago, but that was the comment. The transition, hopefully, to something a little better at the NAMI National meeting in Chicago this summer, one of the speakers said, the brain is the area to be in now for research. This is where exciting things are happening. This is where everybody who does research wants to be. That's the good part. The bad part is, how do we give access to those things to people? My assistant is married to a grade school teacher, and he had told her yesterday about, perhaps might be an urban legend, but the state of California deciding how many prison beds they needed based upon third graders and their reading levels. Now, the person from California says that is absolutely not true, but there's a clear correlation with success in school, and I sort of felt like I was vindicated because I said a long time ago, if you ask third grade teachers, they can say, these 6 kids, they need help right now. They're going to need help for a long time, and if they don't get that help, it's going to be a serious situation. But I don't think we're serious about talking to those third grade teachers and getting this to the people that, the treatment to the people who need it. In our disability practice, when we started 30 years ago, we had a pretty good cross-section of illnesses. Now, if you think about that, the people that used to have heart attacks and go on disability now get stents and go back to work in 3 weeks. I have 400 clients, and I don't think I have more than 2 that have cancer. We do not see those things anymore. It is only, almost only, mental health and orthopedics. And the mental health, part of that is because of baby boomers getting old, but the other part is on-the-job injuries and automobile wrecks and things like that. But with the mental health, it's because we have not made the treatment available to people. I have clients every single day that it's clear what they need, it's getting it to them. Many of them are rural, rural meaning more rural than Columbia, if you think this is rural. And that becomes a problem. But even if they're not, sometimes it's a major issue. I had a client in Columbia who was not getting Medicaid, which is a whole different issue about who does and who doesn't, we were told he is too ill for us to treat at this clinic. Now, I understand that. You've got a psychiatrist half a day a week and a social worker and a psychiatric nurse. You can't treat somebody as ill as he is. He does not need to be in the hospital, but he does need more intense treatment than that. Now, we go downhill from there because we don't have anything else that we can offer him, since he does not have a way to pay for this. I have another client who lives about 75 miles from here, was released from prison. They tried to deal with that issue. They set up an appointment for her to be examined to try to get her on Medicaid. Of course, she doesn't keep the appointment. She lives 30 miles from town. Nobody will take her. She doesn't have a car, and she doesn't get there. Well, what's the consequence of that? And a lot of people would say, well, you know, she needs some personal responsibility. This is a 21-year-old with terrible mental illness, quit school in the 8th grade because she was so anxious she just could not be around those other kids. And, of course, now she's had a hospitalization here in Columbia because of all this. Calls me because she can't get medication. She's now having seizures regularly, can't get medication. This just goes on and on. On the more acute side, and I am only quoting from something a nurse said at a meeting 3 years ago in Columbia, that she had someone who she knew, she was there for the blood pressure, but she'd had a third child. She knew she had schizophrenia, and as the nurse is talking to her, she says, "I'm thinking about killing the children," very matter-of-factly. And so the nurse says, "You know, I've got a whole waiting room, people waiting to see me," nurse practitioner, so they cancel all those. She calls the social worker. After 3 hours, nobody will take her. There's not anywhere for her to be treated. And their solution is to put the children into custody with family services. Well, of course, she says, "Am I going to get my kids back?" And the nurse said, "I hope so," but she can't say yes. I mean, she doesn't know. Somebody else lets her stay with them, but that's the solution on that day for her. The other is a police department telling me that they had to chain a 10-year-old girl to a table because they were afraid she would harm herself, and they had to wait for somebody to get organized to come and deal with her. Now, I will say with that was about 3 years ago. That would not happen that way now, for sure. The other issue that we deal with all the time is sexual trauma. And my concern is, because it's about 25% of my female clients, that it's in the medical record. It's not something I have to ask about. It's already there. So I have to deal with it, because if I go to a hearing and we haven't dealt with it, and the judge asks them and we weren't expecting it, then that's a disaster. But the things that I see regularly in clinic notes are things like he was sexually abused by the next door neighbor several times when he was in the 6th grade, period. That's it. It's not any place else in the notes. Nobody is going to address that issue. And people say, well, I'm not really qualified to treat that, so better that I didn't bring it up. In another situation, there was a trauma issue involving law enforcement, and the city said, we will pay for therapy for 6 months. And this was a witness. Now, during the entire therapy, nobody ever asked about the sexual trauma for years from her father. Nobody ever said, why do you have these scars all over your arms? She has a therapist, but nobody wants to talk about this with her. I am sometimes occasionally the first, but maybe the second after their mother, that I am the person that they tell this to. I remember a second grader within 50, 60 miles from here, in the 2nd grade, she says, I'm being abused at home by my mother's boyfriend, and at school by his brother, who's the janitor. And my older sister told, and nobody believed her, and I sure wasn't going to say anything. Well, now she's 35. She has lots of physical issues and mental, and are we shocked that this happened? Or raped at 7 by one uncle while the other watched? Are we shocked that she's 30 years old and weighs 300 pounds and cries all day? No. I mean, that's not, but I don't see treatment for sexual trauma with my clients on, in most cases, I really would have to say. Quickly, 2 things with the collaborative issues, because I noticed that we were supposed to talk about that. The CIT program that has been mentioned has just done a great job here in Columbia. We've trained over 100 officers with full 40-hour training. The officers have said to me, this is the best law enforcement training that I have ever had. One of them was describing a situation to me and said, this man would have been killed 2 years ago. That's how we would have responded. We get to the scene, he has a knife, he's got blood, and he said, in the academy they don't say, the slower you go, the better the outcome. Don't be in a hurry. And I talked to him for 45 minutes, their broken window finally maced him, and we were able to keep anything else from happening. But he said, I think he would have died. We would have shot him. But it's an excellent program, and we are just thrilled with the way that's worked. The other, I'll just tell you quickly, I have a client who is about 45, has low IQ and is not able to read, was sexually abused by her mother's boyfriend for about 5 years until a teacher noticed some bruises on her arm. The state intervened. It wasn't even in Missouri. And the judge said, she can't go home with you if he's going to be in the home. We know what he brings in a paycheck. She doesn't. And she has to make that choice. And this is not lost on a 16-year-old. Her mother is choosing the boyfriend instead of her. So she's unhappy with her mother for several reasons, but also because she can't read, and that must be her mother's fault. After her mother dies, she discovers her mother couldn't read, nor could her grandmother. The boyfriend was giving her mother drugs every night that he would bring home, which is why her mother wasn't protecting her. And I talked to a retired reading teacher into tutoring her, and she'd come to our office a couple of times a month. And we're starting with books that are cardboard pages that have a picture of a duck and has the word duck. I mean, she is pre-kindergarten is what the teacher says. The amazing thing is that she, after about 4 sessions, she is a different person. She doesn't look the same. I've had people look at pictures of her before and after, they say that is not the same person. Her entire attitude changes. She's going to the gym working out. She has new hairstyle. She is much more confident. And now, unfortunately, she's a little bit ahead of the game and thinks that she can read better than she can. This is a long process. So my wife took over the tutoring, who is a retired English teacher. She was explaining to her what the possessive was and what those little curved things are for, and she cried. She said, I never knew what those were. And Linda said, I never had any other students cry in high school who were learning that. But to see her come in our office, she is an entirely new person because I would say she's reading at the first grade level. I mean, she's making progress and she's proud of that. So those are the kind of things that at least are available that we can do, and reminds me that always there is still some hope. I just want to throw out a couple of quick things that deal with things that came up with other speakers. This was a woman who, she had said to me, my husband asks about my talking. She talks to herself all the time, and she says, I have to get these thoughts clear. I have to say it out loud. And then she says to me, I have thoughts that I wouldn't mention to other people because they would think there's something funny here. She has clearly been, if you can be a little bit psychotic, for a long time. I mean, she was able to work for a long time. But this is an issue that she has not talked to anybody about. It's an issue that needs to be addressed. And that's an issue about, do we put it in her health record or not? Should somebody else track that? In a committee that I'm afraid I haven't been a very good attender for, we had that specific discussion about electronic records, and we started with, we need to protect these things and we need to not have other people having access. After 45 minutes, we ended with, no, we are not going to do any of this. We are not going to treat these records differently. And I would say, with the exception about specific treatment notes, because there is one in HIPAA, I never see that come up, but I did have a conversation yesterday with the psychiatrist who had wanted to say, we bill under psychological notes, so all our notes fit within that category. Well, that's really not what the law says. they have to be treated much differently, and you can do that, and I'm not saying it's a bad idea, but it's important to, I guess, to do it right. Ron was mentioning about people talking about the terrible treatment that they were receiving sometimes and things that happened in institutions. This was a young woman talking about growing up in Brooklyn. She said, when I was in school, I'd call my mom to come and get me every day. The staff was having sex with the kids. And again, are we shocked that she has terrible problems as an adult? I'm glad to be here. I appreciate being able to share some of these things with you, and I look forward to your questions. Thank you.
Thank you. And I was very remiss in introducing Tim Harlan and not letting you know that, was it 3 years, 4 years it took to get the mental health parity bill passed, but though he worked tirelessly in the state of Missouri to ensure that legislation got passed, and so very proud to have been sitting on the sidelines to watch that happen. Are there any questions out in the audience for our panel today?
Hello? Okay, sorry. I am actually glad that you mentioned about California and actually other states, Georgia. They do use the grades of third graders to decide if they're going, how many prison units they need, and that's called the school-to-prison pipeline. So even though they say it doesn't exist, that is something that's going on. But I'm really grateful when you mentioned that they are developing a mental health first aid for youth, for people who are working with youth. And I had a question about that. In particular, I was a high school teacher, and so when I was a student teacher, I had 2 situations during my student teaching year where, there was possible suicidal things. And I remember one day I was during lunchtime, and I kept having this feeling about this one particular student, and I even told my mentor teacher, like, I don't know, I just keep getting this feeling. And one day she just came into the classroom, sat down in a chair, and this is during lunch, and pulled a book from underneath. I was a health teacher at that time, and opened the book to suicide and said, "Ma'am, when are we going to talk about this?" And my eyes just was like, I didn't know. I mean, I automatically, luckily, I had a little bit of knowledge just, because it was health, but really hadn't had any experience like that before or anything like that. And I can't say everybody was sensitive to that in the school. In fact, they felt that I spent too many hours with her. So I think it's really needed to get that training, and I was wondering how you're preparing. I know you said it's still in the works, but I'm also wondering how you plan to evaluate doing pre- and post-test with teachers and other people in the schools.
Well, the best news that I have is that I've already contacted Express Scripts Corporation, who has already agreed they will fund the first pilot of the youth manual. And if you don't think that evaluation piece is not going to be in there, they love that kind of stuff. So that's exactly, again, the plan. Hopefully by that time, the whole evaluation piece for the other manual will be well on its way, so that we'll have, some background area to go. But you're absolutely right.
I wanted to mention that about a year and a half ago, NAMI worked with Pilot Grove High School, which is about 30 miles from here, in this community, about 600. And NAMI Springfield, which is the local affiliate that is best able to work with the schools. Because you can imagine with schools, particularly suicide, if you come talk about suicide, then they're thinking about suicide. If you don't talk about it, then they won't think about it. But they brought their program into the high school for a day. So this is classes of 30 each, the juniors and seniors. One girl stayed for 2.5 hours that night to talk to the counselor. Another boy said he had told his father the week before, "I'm not going to be around much longer." And the thing they tell the students, and some of you have worked at these programs, I'm sure, is you have to ask somebody. And if you can't ask the question, then you can't say, "Well, I just can't do it." You have to go get somebody who will. But you don't get out of it by saying, I just can't do that. I was amazed that that school system would, a small school system could and would do that, and it was a very successful program.
Other questions?
Okay. I just had a question about the community mental health care home, patient-centered healthcare home. That's a long title. Community mental health center, patient-centered healthcare home. Okay. As we form these up, it just makes sense to me, like it does with any healthcare home, to not only wrap around primary care in these centers where these folks get their this is their healthcare home, but also to use technology to wrap around all kinds of other specialty care. You know, we have telehealth in 200 places around this state. The technology is so much cheaper now, and so it's just all so much easier. I'm a dermatologist. You know, I can be the dermatologist for all of your healthcare homes and would love to do that. I'm just saying, shouldn't we think beyond primary care as we're forming these up?
I'll comment, and then Tim can too. First of all, it's CMHC Healthcare Home. No patients. We're not patients. We're people. We're individuals. Okay, so we're healthcare. It's a CMHC Healthcare Home. And then what we're doing is bringing a primary care consultant. The CMHC is not going to be providing primary care. They're not a primary care provider. That is, you know, that's not where their PCP is. We're not making them into a primary care office. What we're doing is introducing them to, what we're doing is giving them a primary care consultant, a person who can work with them and help look at the information that we're giving and help them with their chronic diseases and so forth. But for the primary care, when they go to the primary care doctor, they have a primary care doctor.
So all these folks are going to have to go to a separate primary care doctor?
Well, yes, there are some centers that are both, but yes, they're not a primary care office.
Well,
There's some that are.
some community mental health centers will have physicians, but the whole program is not built on the concept of you have to change your physician to have your healthcare home here. So what's paid for, what's not paid for in healthcare, and that is probably the most critical element, is that the physician consultation time is not paid for. So if a care management team wants to talk to a physician that is not at that organization, that can happen. So the consumer doesn't, because they have their psychiatric rehabilitation and their case and their primary care nurse liaison that helps coordinate their chronic diseases at their community mental health center. That community mental health center may have a physician at that center as their primary care physician, or they may have it somewhere else, and the CMHC can work with that physician, and the physician will get paid for the consultation time, which is unique. And the rationale behind this was, it actually goes back to the FQHC-CMHC collaboration initiative. What happened was, I talked about briefly in 2006, case managers already tried to get everyone a primary care physician. We got to where 90% of our consumers, that's part of how we already saved money in these projects, 90% of our consumers had primary care physicians. Well, then when we started the FQHC-CMHC collaboration, we put primary care physicians in from FQHCs into the community mental health centers. Well, we'd already gotten people primary care physicians. And so the consumers said, well, I don't want to switch physicians. I like my physician. I like my case manager. I like my psychiatrist. The whole goal is to get all of those people talking and working together. Now, if they don't have a physician, or that physician could be at that center, but this is not to rebuild a primary care network within a community mental health center. It's so that you tie the whole healthcare team together, because physician consultation, and this is a weakness in the healthcare system as a whole. This strategy on healthcare home will be helpful, but physicians talking to physicians is not what the systems pay for, and they should. That's where a huge amount of cost savings can occur. You don't need to have a huge specialized report. So I hope that answers there will be primary care physicians. In some centers, where they are FQHCs or rural health clinics, they will have a substantial primary care presence. But in other cases, they will set up a team where they'll have a physician consultation, and they'll work with the primary care system in the local community to be consultants to their teams, so that they can get their case management, their psychiatric rehabilitation, their primary care, nurse care coordinator, and work with the existing physician they have. Is that hopefully that answer?
You want to follow up?
Later.
Other questions out in the audience?
Thanks. No, I guess I had a question about mental health first aid, which is a fascinating program. And I've certainly heard about it, but I love the way you present it. And can it be also used? I mean, I realize that it's hard to engage people who don't have a direct interest or a direct role, but could it be used as a way to sensitize the general public? And is it being used for that purpose? Or maybe an abbreviated
No, that's
approach?
the ultimate goal.
Okay.
And the interesting thing in Australia, once they cracked the corporate wall, boom, it started moving. So that is, and that's the ultimate, is that it should be for everybody. I mean, it might be your wife, your child. We don't know who's going to have a mental disease, and so the goal is to have the entire public educated. We all know ABC. Why don't we know AALGEE? And that I still lean to looking for a national group. We so hope SANSA would take it on. They don't do that, and so that doesn't mean if anybody has any ideas about a national person that we could roll out. And I have to say, and this is a total personal, and you all can criticize me, I did not want it to be with an institution associated with mental health particularly. It's a mental wellness to me, and so I really wanted it to be not associated with mentally ill. And so I still look to the Red Cross. I mean, I plan to have a couple of meetings locally in St. Louis, but you have to, you got to build the product big enough that they want it, and so that's what we're still working on.
Quick follow-up. I'm just thinking, periodically we all get requests from like the Lions Club or the Kiwanis Club or whatever, and obviously a 12-hour course is probably more than can be provided, but I'm just wondering if there's like an abbreviated version that could be used.
Well, to
you
date
can reach
there is
a lot
not.
of people that way.
There's a lot of interest, and it's probably stronger than interest, in condensing the course to 8 hours. The problem is Betty Kitchener wants it 12 hours. I mean, 12 hours is what they've done, 12 hours is, so that's afoot. The big three, the three teams are looking to get it to a one-day deal, and if they do, I think you're right, that would help a lot. The interesting thing for me, I pitched to a major corporation in St. Louis. All the human resource people were going, yeah, this is terrific. Sitting at the table was the chief financial officer, and he just looked at me like, are you out of your mind? He said, I wouldn't give you 15 minutes, why don't you put it on the computer? I mean, bang. And I thought, there's the mentality right there. And so we've got to get past that. You can't, it's not a course to learn on the computer. And the whole human interaction is critical to the teaching of the program. So that's why the shorter you make it, you lose out on some of the fun. And some of the fun and games are hysterical. I mean, we drop dead drunk on the floor. What are you going to do with me? There are all kinds of things like that to really learn the experience of what it's like when your buddies drop dead on the floor. That's hard to teach on a computer. So that's part of the problem.
Well, and I took Betty's class, and let me tell you, seeing her drop dead on the floor drunk is not a good thing. Yeah.
I had a couple of questions. The first is to Betty. Do we know anything from the Australia experience, or are you going to be looking at this in the evaluation component about whether the program identifies new cases or additional cases that could be helped, additional people who could be helped, or does it identify people earlier? Because I think there's a difference. It may do both, but if it identifies more people, then there's an issue of, access for those folks, because access is already tight and all that.
No, you're absolutely right. And that, of course, was the big question. They kept saying to me, okay, Sims, what if you succeed? Well, what are we going to do? We don't have the network out there to take care of these people. So that is a question, and it's a good one, and I don't really have an exact answer, but I do think, I know that the early identification is critical to the program, and that's what they're looking for. How many people will actually be in what I would call second or third stage that actually need all this professional care and things like that, I can't tell you right now, but I think it's a good piece to talk about and to put in any kind of an evaluation as we go along. I don't know is the answer.
And then the other question I had just for Tim, this Tim, is more about the folks who are do not have Medicaid. You mentioned them several times. I didn't want to bring them up, but since you brought them up, but I mean, I think this is a very challenging group. I mean, they're usually folks who have as severe an illness as folks who are already identified with a disability, but are either not able to get disability yet, or because they're just newly diagnosed, or don't know how to access the system, that kind of thing. What can we do for those folks, and will that change in 2014 or whatever when they open up some access?
Well, having kind of followed this and trying to work to support those individuals from advocacy levels for the last 10 years or so, what is often misunderstood by legislators, decision makers, is that because most disabilities are more automatically decided by the disability determinations, as Tim Harlan mentioned. So when a person with mental illness approaches and asks, when they have their crash and begin to have their spiral towards disability, it's years, usually years before they actually get the Medicaid card, and we've not been able to successfully explain that to the decision makers. So there's a perception that when we're cutting the non-Medicaid funding, and it's a perception, it's not for lack of effort. Many members of the General Assembly, former ones, including former ones from this room, have made this case. But the perception is those funds that have supported the non-Medicaid consumers are going to people who aren't that sick or people who aren't that poor. And it's a misunderstanding about what a Medicaid has been. And if the 2014 coverage, even if it goes to the 133% of poverty for Medicaid without the insurance mandate, that will be huge for that 24-year-old that's first psychotic break schizophrenia, because they will be poor enough for Medicaid, just as most decision makers think, because you're that poor, and you show a disability, you have Medicaid, and if that will be huge, even if they turn over the mandate part on the Supreme Court. If the Medicaid coverage, 133%, goes through, persons with mental illness will be the biggest coverage winners of them all in this whole group of unserved people. And that is what hopefully, if the judgments go against the act, that it's focused, that Medicaid expansion covers, because people with mental illness, it just takes years to actually, they have to crash far worse, as you well know, Doctor, they have to crash far worse than they would otherwise if they could get stabilizing care in their first crash, which they can't. They can get hospital care, but then there's no funding to support the indigent care. And I don't know if Tim Harlan wants, this is who he's seeing. His 400 people coming in are people that are in their crash mode.
John, there's I guess you would call it a study, but I was at a NAMI meeting in St. Louis a few years ago, and they had tracked, I think it was mental health cost and people who had been in the city jail system, and identified the 50 highest users, but these were not new people to the system. We're not bringing somebody in that hasn't been there before, and so we have this huge cost. They're in the system already. They're in the emergency rooms already, and I thought they made a pretty good case for that. But the issue with Medicaid, I see people every single day, cut off because I didn't keep an appointment. One, I was in the hospital or I was in jail. And this will happen to people. I was in Minnesota because I went for my grandmother's funeral. My mom was supposed to come and get me, and she didn't come for 7 months. And so I didn't use my Medicaid, so I lost it. This is some of the terrible illness. And I see people not being approved who I think would have been approved 2 or 3 years ago. I see people that that FSD doesn't get the records. They say we don't want something 2 years old, so they can't make a very good decision. And frankly, they're not set up to be going around getting. I mean, in theory they are, but they're just not going to do that. So I see people every single day that need Medicaid that are eligible, and they can't get it because they just can't get into the system. One who said, "I've never been to the FSD office, and I'm afraid. I just can't go there by myself." Well, will his mother go with him? I don't know. We're going to have to see. So it's those kinds of things that really interfere, and then ultimately, of course, result in a much higher cost. But that's awfully tedious to explain to legislators. Maybe not to Senator Sims, but to a few others.
Teach them to listen first.
We have another question over here.
I work with school nurses who work with school children, and so my question's more about the Affordable Care Act, and do you think that any of those dollars will go to early identification and more treatment earlier in prevention for young children? We hear from the school nurses all the time that the biggest growing population of chronic illness that they seem to have are children with mental illness or the potential for mental illness. And they'll go on to say that we've given them the best practices for managing children with asthma and diabetes and seizures and many other things, that we know how to treat that. We know how to care for them at school. We actually have, from their primary care physicians, an emergency action care plan and a health care plan that will help the school nurse and the school team to more fully include that child in school every day. So it would seem to me that hopefully in the next few years we could also have a mental health care plan or a mental health promotion plan or something that the school nurse would know, if you see this, do this. We have to accept that mental health is and mental health deficits are a chronic illness. So I guess, I'm sorry, I said a whole bunch, and I guess the question is...
That's a great question, Marge.
Are there dollars, and will I look forward to seeing them before I retire?
Well, I throw that open to the panel. Who would like to answer that question?
Well, there is funding in the Affordable Care Act that's a prevention fund, but those dollars could well be tied up with the deficit reduction piece. And not a lot of those dollars have been put out yet, and they're not clearly defined for those types of programs. I think there's other policy challenges that are probably more center around the issues you raised, which has to do with IDEA and special education and the requirements for education to pay for certain health care needs when a child meets special education requirements. That has really been a challenge and a barrier towards mental health outreach and identification in schools. So my answer is there is prevention funds, but I don't think that largely gets at the challenges you're bringing. I think that's more of that's a different policy challenge that needs to be faced at the federal level at some point when we get past how much money are we going to take out of the federal budget.
Other questions? Well, let's go ahead and give our panel one more round of applause.